you, and I am with Christiane Charret from Québec. The last time when the last webinar we did, we talked a lot about the impact of the prenatal classes on women, and people seemed interested to know what is the content of these new prenatal classes. So this is what we will present today. Before we start with the content, we want to explain a little bit our reflections. Why did we change the content and how we did that? So before the prenatal classes, there was 5 meetings in the evening, once a week, and each meeting was lasting 2 hours. There was 10 to 12 couples, so that means a lot of people in every classes, from 20 to 24 persons. There was major problems with this way of doing things. First, most of the pregnant women were very tired in the evening, and from 7 to 9, it was a bit late for them. So the listening at the end of the classes was not as good. The classes were rushed because we had 2 hours, which means time to settle, the pee time, time to leave. So by the end, this left us about an hour and a half of content. I told you there was too much people, so not many time to exchange between couples. No time to listen to their needs, their fears, and no time to exchange between them also. There was no time for practical exercises, and most of the couples love it. And the way the content was given was a magistral class, so there was a teacher in front and people were listening. So we worked a lot with the evidence-based, showing all the advantages of physiological labor and delivery, and we decided to prepare the woman, the couples, in fact, because by working with them, the mentality will change with time, and also by working with women, they will come to our center well informed. They will know their rights, they will know what they want, and this puts a little pressure on us also, which is good sometimes because it pushes us to do better and better and better. Because when it comes from the couples, well, we all want to please them, so we thought it's a good way to change the mentality in the population, but also in our department. So we realized that we have to completely change the approach. We wanted to take time to discuss with the couples, to listen to their fears, to listen to their need, make sure they understand the content, and to have more time with them. We had to decrease the number of participants in each classes. So now there's in between 5 to 8 couples in each classes, which is much better than before. By doing that, a money problem popped up because we said, okay, if we have less participants in each class, well, this means that the teacher has to be 2 times more present with them, which means pay twice to give the class. So she thought about a totally new way to give it. So now, instead of being evening classes, it's weekend classes. So the couple comes for one weekend, 2 mornings from 8 to 12 on Saturday and 8 to 12 on Sunday. So that's one group. And the other group comes one weekend too, from 1 to 5, I think, on Saturday and 1 to 5 on Sunday. They have the whole content in this weekend, and this includes the visit to the department. So the couples, they really love that way of doing things because they come, especially the men, they like it because they come 2 mornings and then it's done and the visit is included because before they had to have another evening to visit the department. So there's less people, we have time to practice, they have time to exchange between each other, the visit is done, so it's really a winning way to do that. Okay, who did the content? Well, I did it. So after I read all the books we have in our department, Simkin, Verena Schmidt, Walsh, and I did a whole new content. And of course, we kept some of the old content too because there's things that couples like to know. They like to hear about interventions and all that, so we kept that part. But all the content on labor and delivery, it's a bit different. We don't spend too many time with the stages and all that, so you will see the content soon. And now, who teaches the class? Well, it's a nurse from our department, and that nurse has a lot of experience. I think she worked with us for 17 years. She's also on IMBCI. So what she did is she looked at the content and she colored it to her own way. And her strength also is she's very good to communicate with people. So and why did we change a nurse? We chose a nurse from our department. It's because she knows how it works on the department, so she's clearly able to answer specific questions that the couple might have. So, and she can really reassure them too, because she knows how we work. The other interest of having her doing that is because she has a big notoriety in the department. Well, it's easy for her to make modifications with us because she works with the couples and with us too. So she's like the bridge in between the couple's needs and the thing we have to change in our way of doing things. Last thing we did is that all the staff in the department, doctor and nurses, are formed with the new content. So they all know what the content has, so they know what, they understand if a woman comes with a specific demand, well, they understand why, because they were sensitized to the new content of the prenatal classes. So that's the way we did things. And the new prenatal classes are ongoing since about 1 year now. And so far, we are very, very proud of it. And we have good success. So, and the other thing that is very interesting is that these classes are in an ongoing adjustment. So we change them when we need to. It's not a static thing. So basically that's it. Okay, so we're going to look now at the content. So each couple has a PowerPoint presentation. So they have it in their hands, so they can follow the PowerPoint. They can write notes. They can interrupt at any time. They can ask questions whenever they want. So, and sometimes what is good to have also a copy of the PowerPoint is sometimes at home they have a question in the evening. While they come back on the next day, they can ask it. So that's the plan for day one. So we talk about the physiology of labor and delivery. We discuss about positions, massage, breathing. We talked about a lot about the hormones. That's one of the major points that is brand new on these classes. We look at clips from the film Organic Birth, and we choose 2 specific clips for different reasons. We talked about pain, the reasons and the function of pain. So that's new also. That's something that was not discussed before. Also, well, when you should come to the hospital. And the last point, perineal massage, was a demand from the couples. At first, we didn't talk about it, and we had a recurrent demand for that, so we had it. On day 2, we talk about pain relief with medication, and we talk also with pain relief with all the alternative methods. We show pressure points. They will practice pressure points. We show different positions during labor. We talk about all the medical interventions which could happen. We also discuss about visualization, different positions for pushing, and we present position not because we impose them to the woman. It's more for the woman to realize that they can just push in the position they want, and we notice that they all look movie and pregnant women in movie. When they push, they always have the gynecological position. So we want them to realize that they don't have to push that way. We talk about prolactin, skin to skin, all the environmental factors that are helpful for the bubble preservation. And at the end, there's a big discussion between couples about the advantages of physiological labor. We discussed about the rhythm. So we want the woman to realize that every woman has a rhythm, and every baby has a rhythm also and is unique. And that together, well, they form a dyad, which is unique too. If they have another pregnancy, it's a different dyad, the rhythm will be different. And we made the emphasis that the personal rhythm allows adaptation to pain for the mother and baby. So it's very, very important to respect the rhythm. And why we tell them that also is just they should realize that they cannot compare themselves with their sister or their cousin. Everybody is different. and it's important to respect that difference. Okay, well, of course, we talked about the Braxton Hicks contractions just to help the couples to identify them. So I won't stay too long on that slide. We also discussed about the false labor, what is it, what you should do about it, and the nurses in our department are very, very sensitive to women who have false labor. We really pay attention to the word we use when we talk to them, and we show empathy, and we really avoid minimizing the impact of false labor because we all know that it can be very difficult for some women. So we will take time with them on phone, or if they come with us, to explain why this happens and why they can do to help going through that. We go briefly on the different phases of labor, but we take a bit more time with the first phase of labor, and especially the latency phase. And we explain to the woman what's happening there, that the contractions become more and more regular, that this phase is very important. It's all the hormone and in installation. And this latency phase usually occurs at home, and we sensitize the woman that if they come at the hospital and they are in latency, they will go home. We will return them home. Of course, when we do that, we give them tools to deal with it at home. And also we do lots of consultation by phone, especially at this stage of labor. We also, when a woman has a very, very long latency and they just cannot go on anymore, we offer also to have them at the hospital, and we can give them medication for having to rest, sleep, but after they know that they will go back if labor is not starting in the active way. Okay, then the active phase. So we explain what's happening during this phase. And what should you do? Well, we tell them have support. You can start your pressure points at home. You don't have to wait when you come to the hospital. You can move like you want. Try to maintain a calm environment. And when they call us on phone to see that they're in active phase, well, we tell them, if you're comfortable at home and you feel safe, you can stay for a little while at home. So some women now, they feel more comfortable to do that, and when they come to the hospital, they're already at 7-8 centimeters, which is very good because this avoids lots of interventions, and they're very, very proud of themselves when they were able to do that. And they know they can call us anytime. So if they have a doubt, if they're not sure if they should come, well, they just give a phone call, and then we talk to them, and sometimes just by listening their breathing way and the time of the contractions, we can tell them, well, maybe you should come. Or maybe you can stay at home a little bit longer in a bath. So we do lots of phone calls, consultation. Okay, a little slide for them to understand when we say that the cervix is open to such and phase to such and such, so they understand now what it means. So that's just to help them because it's our way of talking, but for them it's not that clear. Okay. Then we discuss about the second phase. So we discuss about the passive, so they don't feel the urge to push, and when they don't feel the urge to push, well, just don't push. And if you feel the urge to push, well, you push. And we really encourage women to do what they feel to do. So we try to center them to themselves. We really try to put them in contact with their inside, so because they know. So we work a lot with that. Their instinct. We told them to listen to their instinct. Je peux peut-être mettre la souris ailleurs. Comme ça, tu pourrais taper. Puis, ah oui, c'est vrai, tu as raison. C'est bon. Okay. The third phase, we don't spend too many time on that, but why we talk about it is because we want to make the emphasis that even if the baby is born, the third phase and the fourth phase that we will see later is still extremely important for the hormones and the contact with the baby. So it's important to keep a quiet environment. It's not time now to jump on the phone and call the mother, the grandmother, or to jump on Facebook. You really have to stay in the bubble. So we do that. And in the third phase, well, the nurses have things to do, but we are very, very, very discreet. We will never interrupt a contact to do our things. We have a way to do things. We're very delicate, and we don't disturb the bubble. So we're very sensitive to that. And the fourth phase, which is about 2 hours after birth. We discuss about it because we just make the emphasis that this phase is the period where woman and baby learn about each other. They are in contact to each other. It's the time when breastfeeding is started. And also, there's a surge of hormones, very important for breastfeeding in the long term, and also the altruism. So we discussed that with the couple. Okay, so then we position, exercise, massage, breathing. That's more on a practical way that we do that. So the couples will do together different positions. They will practice massage and breathing. Well, we don't spend too many times on that. We just let the woman breathe like they want to breathe. So. When we do the massage technique, we just explain to the couple how it works so that they understand. So it's very simple. We kept it in the very simplified way, but what we say is that the non-painful stimulation, the massage, will in a way inhibit the painful message. So the man will feel free to do that, and if the woman doesn't like it, she will tell him. So we also encourage a lot of touching. So that's the next slide shows different techniques. We have on the next one the massage of the piriform that we show. So they practice in classes together. And women who have back pain, they really like the pressure point on the piriform and the massage on the piriform. We show the massage on the SACRUM area and slides of different positions they can do at home, not only when they come at the hospital, but these are all positions they can practice at home. And here we go. Now, one very important thing that we want to emphasize is the environment. So, we really made a parallel between giving birth, which is a very, very intimate experience, and having a sexual relationship. And why? Well, we tell the couple it's mainly exactly the same hormones working in both situations. So what do we need to have these hormones to work very well? Well, you need privacy. So if you come to give birth with people with you, well, you really have to feel comfortable with the people in the room. You need your liberty of movement, so you should be able to move whenever you want, how you want to move. You need the twilight, no neocortex stimulation, and our staff is very, very sensitized to this point. So we barely don't question the woman anymore. And so if we have a specific question to ask, well, we ask the husband. No disturbing noises, no clock. So when clocks are broken in our room, we just don't replace them anymore. We respect the rhythm, and we discussed it at the beginning with the first slide. No spectators. So the nurses in the room, they were not standing and look at the woman giving birth. They will be there to help, to do pressure point with the husband. They will leave the room if they feel that they can. And if they're in the room, well, we try to keep busy without doing noise so that the woman doesn't feel like observed. You need warmth, you need support, and you have to feel safe. And the safety is very, very important. And sometimes we just make the parallel with a cat giving birth. Well, they will never give birth in the little paper box that you prepare for them. Huh? They always find their spot where they feel safe. Well, for the woman, it's exactly the same. It doesn't feel safe. The bubble won't be there. The hormones won't work very well. And we may have a dystoxic labor. Okay, then we talk about the oxytocin hormone. So what does this hormone do? So stimulate contractions, stimulate secretions of endorphins, decreases the risk of hemorrhage, promotes milk ejection, decreases anxiety, so contribute to well-being and raises body temperature. So they understand exactly what the oxytocin does. Then we discuss about the role of the endorphins. So tell them that it's like a natural morphine. They secrete it by themselves, and it helps to decrease the pain sensation. They make you relax, decrease the stress, and make you in a hypnotic state, like a trance state. So now that they know the role of each hormone, we will ask them a question. What promotes production of oxytocin and endorphin? So we ask the questions to the couples, and we want them to give the answer. And after, well, we go through the list with them. And basically, it's mainly the same as the favorable environment. So couples really enjoy this exercise, and it really makes them a clear understanding of how it should be in the room to have these hormones to really work well. So we go again through the list with them, feeling safe, confident. You have to see the light, you have to be well surrounded, touch, massage, warm water, support. Non-judgmental atmosphere is very important. So again, we sensitize the couple. If you have a friend or a mother in the room, well, you really have to feel comfortable with her being around, because it doesn't take much to disturb the equilibrium. No clot, skin to skin, and contraction. And the next slide. It's again a question that we ask the couple. According to you, what inhibits the secretion of oxytocin and endorphin? Now they know the answer, I can tell you, because we discussed a lot about it. So they understand very well that the environment should be very comfortable. Being watched is not that good. The bright lights, strangers. And talking about strangers, in our department, we developed a code of communication to avoid to disturb the couple during labor and delivery. So if we need to talk with the staff member in a room, we gently knock on the door and we stay outside. So the nurse will get out the room and we have that discussion outside, and then she goes back inside. So and that's clear with the doctor, with the inhalotherapist also. So we really, really respect the environment to avoid the presence of strangers in the room. Every annoying stimuli is disturbing. So too much exam, the pushing with fingers in the vagina. So when they know that, well, they can see, well, no, I don't want an exam. It makes them in control. Continued stress, cold temperature, to be questioned all the time, restricted mobility, uncomfortable, unjustified procedures, pressure to perform when all the family waits outside the door, separation of the mother and the child, epidural painkillers, and on day 2 we spend a lot of time on that specific point, and synthetic oxytocin. Then we talk about adrenaline. And what's the role of adrenaline? So we all know it's a fight or flight hormone, so we explain to the couple what this means. And we explain to them that if there's too much adrenaline, it will inhibit the oxytocin and it will inhibit the endorphin. So when you're in labor, we really work to minimize the secretion of adrenaline. When it's time to push, sometimes the rush of adrenaline brings the energy rush to really push. But when you're in labor, we don't want that hormone. And on the next slide, we explain to them what stimulates adrenaline. So if the woman feels stressed, if she's afraid, if she's anxious, she's in very in pain, very cold. She feels the presence, the surrounding is unfriendly. All this will stimulate the secretion of adrenaline. And then we explain them, well, if this happens, then the oxytocin is not secreted anymore, the endorphins, and then the labor becomes dystopic. So we have to work on these different points to have the labor comes to have the oxytocin secretion maximized again. What decreases the adrenaline? Well, calm and safe environment, warmth, intimacy, basic needs are met, and only a few helping people around. Then we always do a little recapitulation with the couples for them to understand how it works in chain altogether. So we say that oxytocin is secreted firstly as a result of the baby's head crushing on the cervix, and then we have contractions. And to have the right dose of oxytocin to have an optimal labor, well, you need a good environment. And we tell them that oxytocin is a shy hormone. It's the hormone of love, so you really, really need a good environment for it to be secreted at its maximum. And then if the oxytocin production is not, it becomes insufficient, labor becomes less efficient too, and this may lead in medical intervention. So we have to work in the environment to try to maximize the oxytocin secretion. Also, we explain to the woman that the contrast between rest and contraction will stimulate secretion of endorphin and oxytocin. And the endorphin will really help the sensation of well-being and pain relief. So we like to do those recapitulation with them so that we see that all we discussed before, it all interwing with each other. Also, by staying in your bubble, you will have more endorphins, more oxytocin, and the only time when adrenaline becomes useful is when it's time to push. So before that, we keep calm and we work with other hormones. We tell them also that there's a fine-tuning to stay in the bubble. And if we disturb that equilibrium, that bubble, it takes lots of effort and time to regain that state. It's not irreversible, but it's not that easy sometimes to go back in the same state of bubble that the woman had before. So the key word is just don't disturb it at first. Also make the link with the sexual relationship. Well, we tell the couples, well, after intercourse, human hormones have raised, bringing a sensation of well-being. And then we tell them after birth, these hormones are at a much greater level. So we can just imagine the feeling. Then we check two little clips from the film Organic Birth. The clips we chose are on purpose. One of them shows a couple working together at home on the latency phase. So the woman, she used the ball in her bed. The husband makes massage and pressure points on the SACRUM. And the other clip, it's a woman who she has birth at home. She really verbalized her fear, and it's nice to see how the midwife and her husband help her to go through that. So that's why we chose those clips. And after, the couples are welcome to share their impressions, to ask questions. Sometimes some couples have never seen birth before, so they're surprised. They can express their fear, and the nurse giving the prenatal classes will take time to answer all the questions and to reassure the couple. Then we talk about the meanings and the functions of pain. Why should we have pain in 2014? And we explain to them why the pain is there. And the first point is the survival of the species. So when pain starts, when the contractions start, well, it gives the signal that something is coming. And it really forces the woman to concentrate on the event. She has to really listen to what's happening. So feeling the pain also leads the woman to adopt the appropriate position to help the baby find his way in the cervix. So also we discuss about the bridge, the rite of passage, which is not that common in North America, but in other cultures it's a very important thing. We discuss about the letting go, so that when you're in labor, you have to let go. You have to go with the flow, and that's a very good preparation for parenthood, because everybody knows that when you have kids, well, you really have to let go so many things, and so it's a really good preparation, and also it's a wonderful experience for the empowerment, for the woman, for the couple too. And also pain will help for the productions of hormones, and it's essential for the secretions of endorphins and the natural oxytocin. We also explain to them that the pain of labor is different. First of all, it's not because of a pathology. It's really for a good news. And there's breaks. You have pain, you have rest. You have pain, you have rest. And also that pain is self-limited in time. It will stop at one point, for sure. So that's a bit different. The way to view that pain is different. The next slide, well, when should you go to the hospital? So we give them clues if you're in premature labor. I won't go very long on that slide. But as you can see, we left our phone number. So we always tell the woman, give us a call before coming. Sometimes we can just resolve the problem by phone. But also we like to know, we get prepared to receive you, so we encourage everybody to call us. The next slide is the massage of the perineum. We also look at the movie presentation, The Tree and the Nest. And this also opens discussion about labor and delivery, and the nurse is there to answer the questions. In this movie, Okay, and it's this movie while Paul Gagné do presentation and Michael Klein too. And they discuss about the physiological labor, and we see a lot of midwives from Québec too. It's a very, very, very nice movie. And then that's the end of day one. And sometimes the visit is on day one, sometimes it's on day two. It all depends on the time left and also on the occupancy on the department. On the next day, that's the plan of the day. And we saw it at the beginning, so I will switch right away. So we talked about pain medication. So what's the choices? We have narcotics and we have epidural, and we briefly explain how they work. And next, we'll discuss a lot about the advantages and the risks of epidural. So of course, the advantage, we all know them, so I won't go very, very long on it, but we make the emphasis, though, that if the epidural is made too early, at one point it doesn't work anymore, and when the epidural doesn't work, the pain seems to be overwhelming. So we have to pay attention when we do it. On the other hand, with some pathology, the epidural could be recommended, like a preeclampsia, for example. And it's a tool also for some women who are extremely, extremely tense. Sometimes these women, well, they benefit from it. Now we have a long discussion about all the risks. And we just realized that people don't know that. So we talk about the risk that there's more stimulation with chemical oxytocin, there's more artificial rupture of the membrane because the labor has slowed down, and that's very common. This also leads to a longer labor because when it slows down, then we have to do an action, and sometimes the action doesn't work right away. So this takes time. We noticed also that there's more posterior presentations with women who have epidural because they just don't have that intuitive positioning anymore. So they tend to stay more on their back in bed. So we work with them, we work with position, but it's not intuitive anymore. More vacuum delivery, more forceps delivery, and more episiotomy. And the pain tolerance also, when the epidural fade away, is very low because the woman did not develop endorphins anymore because she didn't feel pain. So when she starts to feel pain, it's like bam, it's so drastic that sometimes they just cannot handle it anymore. Urinary retention, hypotension, well, mainly on the induction. Headache can be a side effect. Inefficient pushing is something we see a lot. They don't feel the contractions, so they don't know when to push. So we have to coach them, and it's not that easy. And also maternal fever can happen, and this leads to a lot of interventions on the mother, but also on the baby when he's born. We can have bradycardia of the heart rate. Also problems with breastfeeding because suction reflex is not as good and muscular tone can be decreased. And also the baby can be more irritable because he did not have the endorphins of the mother because she didn't feel pain. She doesn't secrete them, so the baby doesn't benefit from it. So it's all discussed and explained to the parents. And we find that all couples should be aware of this to make a clear consent or a clear decision when they decide to go for it. And what we notice is that by knowing that, some women will have their epidural, but they won't take it as early anymore. They will really try to push their limits the further they can, which is very good. So you don't have epidural at 4 or 5 centimeters anymore, or barely. It's really rare. After, well, we talk about the non-pharmacological methods, and we also make practice with the couple. So, well, you all know them. So the support does that to remove the massage, the pressure point, the full compress, autohypnosis. We have a nurse who has a formation on autohypnosis, and we have a nurse who has a formation on massage. So they help all the staff. They give formation to all of us to give us tools to work with that. Also, they will practice the pressure points with the Prenatal method. And the pressure points on the end, on the SACRUM, the piriform. They will talk about the mental preparation, the massage. And we also explain briefly how the pressure points work so that they understand what the mechanism of it. So we explain to them that when we create a second painful site, the brain will forget about the first site of pain to concentrate on the second one. And also there will be more endorphins secreted, which at the end will help for both pains. So after the slides, just to show where to do the pressure points. So when they practice, well, they can visualize the, where to do it. And we also have a skeleton of a oh yeah, well, we have a skeleton of a cervix. Well, and so they can visualize the effect of movement on the hip bone. They can understand the importance of asymmetry. They can visualize also the sacrum and the holes of the sacrum. They can visualize the piriform. So okay. So other slides. And for the mobilization, we just make the emphasis that you should move as you feel. So if you want to sit, you sit. If you want to go on your left side, you do it. If you want to walk, you walk. You really should move like you want. And by the end, what does it do? It helps the baby find his way through the pelvis. We show the asymmetry with the pelvis that we have, and we explain a bit the advantages of the stretching position. It makes more space for the baby, especially if we have to work with the position. If the baby is not well placed in the cervix. And the next slides are all different positions. And of course, we don't expect the couple to use all of them when they come to give birth. But we show them in advance because they can be used at home for comfort. And also, it opens a range of things that the women can do, because sometimes they just don't realize that they can use all these different positions if they feel like doing it. So I think the next 5-6 slides are just picture of positions. And it's nice because they can be very creative with all the tools. They can be creative with the ball, with the cushion, and yeah. And also we tell the woman to lean forward, to have positions leaning forward to avoid posterior baby. So during the pregnancy, they can do this position to help the baby turn around. The intervention, well, I won't go through all of them with you, but we do all of them with the couple. And what's interesting, you can notice that we put stripping as an intervention. We talk about induction, we talk about service. We also talk about the artificial rupture of membrane, the artificial oxytocin, antibiotics, intermittent auscultation. We talk about continuous fetal monitoring as an intervention, and the women, they are aware that if their pregnancy has nothing peculiar, no hypertension, no preeclampsia, they have the right to have intermittent auscultation. All our staff is formal auscultation, intermittent auscultation, and we have criteria to use it, and we all love it. The other point I want to bring attention to you is that in the intervention, we put vaginal examination. So, and that's a different way to view it. So for us, a vaginal examination is an intervention. So before doing one, we have to ask the question, why do I do it, and what will I do with the result? Epidural, of course, we talk about the vacuum, forceps, episiotomy, and dissection, of course. Okay, and when we finish, we do a recap again, just to show them the cascade of intervention. So each intervention, of course, named above, will cause a cascade of intervention. And let's say we start with the epidural. You need more stimulation with oxytocin. And if you have oxytocin, you need a continuous monitoring, which reduces your mobility. If you don't move as much, more posterior baby, bring a longer labor, which means that you will be tired. We could have a vacuum delivery, forceps, and by the end, sometimes breastfeeding problems. And each intervention that we could take individually, we could do a cascade of interventions after. So we do that for the couples to realize that sometimes an intervention that we think is not that major, well, it will create something. So wherever possible, it's best not to intervene if all is going well. And we took a citation from Bonaparte, and she says, by managing pain with non-pharmacological methods during labor, or at least by putting off the time to use an epidural, you increase your chances of having a natural childbirth that is safe and satisfying for you. So we made the emphasis also for putting off the time to use an epidural. Of course, we don't want the woman who asks for one to feel guilty of their choice. We have to be careful of that. But we will work with them to do that sentence, I think it comes from the OMS. A normal delivery, if it is at low risk, only requires a careful observation by a midwife or skilled attendant, so to detect early signs of complication. It does not require any intervention, only encouragement, support, and a little tenderness. The nurse will discuss about visualization. Some women work very well with that. They have their, they put music on their iPhones, and they just work with image in their brain, and it helps. Really, it helps them to go through the pain and the labor. And at the end, we show some delivery positions. And again, here it's not because we expect the couple to do them, but it's more to sensitize them with the different way that we can deliver a baby. So if she feels like doing that position, well, she's not weird. It's totally okay with us. Every position to push is good. So we just show them all different ways so that they can feel free to use them if they wish to. At the end, we talk about the prolactin, the hormone for the milk synthesis, and what this hormone do is increase the feeling of pleasure and well-being, and also it's a very important hormone for altruism. Stimulates the secretion of oxytocin too, and during pregnancy, well, it will help with the growth of the mammary glands. And why we talk about the prolactin is because we want the couple to realize that the fourth phase, the 2 hours after birth, is very important to the secretions of prolactin. That's why we try to stay in the bubble, to keep quiet, stay with a calm environment. And next, we just again explain what stimulates and what inhibits prolactin. And we can see that what inhibits prolactin is stress cortisol secretion. We have a little slide on skin to skin. So we explain the importance of skin to skin for breastfeeding, of course, but for the hormone secretion, for the attachment, and when you do lots of skin to skin, well, we observe that the duration of breastfeeding is increased. And also it's very helpful for the neurological development of the baby. And the effect on the baby also, the baby is calm. It has a good thermal control, a good glycemic control, and his vital signs are very stable. So, and especially when we have very small baby, the premature baby, your low-weight baby, skin to skin is extremely good. And then we ask the question to, according to you, what can help physiological childbirth? And most of them, they say, well, the environment. And the next slide is to open discussion between the couple. So what are the advantages of a physiological birth? And we let the couple discuss together and ask their questions, and it closes the 2 days of prenatal classes. So that's it.
Thank you so much, Julie. This is Deborah, and I want to say to Christiane and you and all that work with you, what a fantastic, not only presentation, but classes that you've created. And I can see that I'm sure many people have questions and comments.
Actively answering them.
So I see so many comments of wonderful and so much detail and nuance from Asha and Susie. Thank you. Are there questions from the group? Yes, Maria says.
She says, well, all the parents understand, it makes so much sense, so that when we just explain to them, they all understand the content, they all understand the importance, they all understand the meaning of all this.
There's a question from Maria that she says, I wonder when the course is designed as kind of a crash course or crush course in a short time, when do the women have time to practice, and do they like or need more time together?
I don't really understand the expression crush course that Maria asked, but when the woman has time to practice, well, they have time to practice during the prenatal classes, and they have time to discuss together.
Okay. And so Anna's going on because some people missed the very beginning. So can you explain again when these are and how much time there is?
Okay, well, for labor and delivery, it's 8 hours class, and it's divided in 2 mornings, one morning on Saturday and one morning on Sunday for one group, and the other group is the same thing, 8 hours divided on 2 days, but it's in the evening on weekends. So total 8 hours divided in 2 mornings, so 4 hours on Saturday and 4 hours on Sunday. And the visit to the department is included.
So there's a question here. Do you get comments from parents that they would like more time?
Are these classes
Maria's asking.
These classes are for groups of expecting parents, and the people working on the department also had the content of the prenatal classes. But yeah, it's really aimed for the expecting parents. Besoin de plus de temps? Non. Non, parce que le temps est bien utilisé, parce que 2 fois 4 heures. So far, the parents, they seemed okay with the 8 hours. But of course, this 8 hours is our part, and it's labor and delivery. They have classes with the CLSC, the Community Center for Breastfeeding. So, but that's a different thing. It's not us that are giving it. But for labor and deliveries, it seems okay with them so far, the 8 hours. Et les gens qui donnent les cours pour l'allaitement et pour l'introduction à les parents, c'est quand même notre équipe et c'est vraiment pour l'allaitement. C'est notre équipe, mais ça doit être aussi. Oui, ça trouve. C'est sûr. Non, c'est parce que là, j'ai marqué le numéro. Okay. Thank you, Marie. I will do
I was wondering, do the couples stay in touch? Do you have a reunion class where they come back to share their stories and their babies? I was asking if you have a reunion. Do all the people that attend your class get a chance to come back after and share how their birth went with each other, meet each other's babies? Thank you, Maria, and all that I know that are leaving us now. We'll stay a few more minutes, but I do want to thank everyone for being here, and most of all, thank you, Julian, Christiane, and Helen for making this presentation possible. I think it's been really inspiring to see the work that you're doing, and I know that many people will be watching this after. We will send out the link as soon as it's available for the recording. So I thank you very much from all of us for this great presentation and the amazing work that you're doing.
There's no postnatal classes for the group, but we have the clinic for the babies, the clinic babies in the community center, and all the parents are welcome to come to these clinics with their babies, and they can exchange together at this clinic. And there's also a nurse. She can help her breastfeeding. She can weigh the baby, answer questions. So if they meet together, it's probably at this clinic.
So are there any other questions?
Deborah, this is Ray. Hi, everybody. I see Kathy Hirschdorfer asked, could you comment on how the participants also influence the content of the course by relating their own experiences?
other questions?
Oui.
Did you hear the question, Julie?
No.
Kathy Hirschberger commented that your presentation, it's in the chat box, that your presentation adds to the increasing evidence of the value of group antenatal information. And she wanted you to comment on how the participants also influence the content of the course by relating their own experiences. And then she states, what I mean is, have you found some elements of parents teaching each other?
Well, thank you for your attention.
Vous comprenez? I think they don't understand.
Okay.
Il faut que vous alliez voir les messages parce qu'il y a une question. Est-ce que les parents
J'ai répondu.
influencent le contenu en partageant leur expérience?
Ah, mais pourquoi elle n'est pas écrite?
Elle est écrite, mais c'est parce que les questions se succèdent rapidement, donc vous ne les voyez pas nécessairement toutes. Il faut remonter ou descendre avec les petits triangles. Là.
Okay. Donc, est-ce que les parents influencent le contenu?
Oui, en partageant leur expérience. Puis là, il y avait quelque chose d'autre après que je n'ai pas vu. Là. Oui.
Well, of course, when the parents come with a specific point or something they want to discuss or a specific experience, we have time to answer that point. And if it's something that if it's a demand that we notice which is recurrent, we will change the content or we will add it. Or sometimes we notice that if some information they don't seem that interested with it, we'll remove it. Of course, it's an ongoing process. Right? It's not a static class. The content changes a lot, and it changes in the last year.
Okay, our recording is about to end, so I want to again thank you so much for this amazing presentation. And as I just wrote in the box, it's the content, but also the caring and the nurturing. You can just feel the amazing opportunity that you're providing.
As if on an official way, but during class, when they exchange together, while the experience of someone is very welcome, and we can use it to clarify some points on the classes, of course.